Good day, my name is Althea, and in this video, we're going to talk about B-cell deficiencies. We're going to talk about its description, its pathogenesis and clinical manifestations, its diagnostic and lab procedures. We're also going to talk about its treatment modalities, its nursing diagnosis and nursing management, and also its medical management, and also its prognosis. But before that, I'd like to give a very brief overview of the immune system. First, let's briefly talk about the immune system. The immune system is the body's biological defense system. Its main purpose is to identify self from non-self. The immune system identifies and defends the body from non-self proteins, viruses, bacteria, fungi, parasites, and other pathogens. It is made up of special organs, cells, and chemicals that fight infection. The parts of the immune system are white blood cells, antibodies, the complement system, the lymphatic system, the spleen, the thymus, and the bone marrow. So now let's focus on the bone marrow. The bone marrow is the spongy tissue inside the bones that produces blood cells. The bone marrow produces red blood cells, platelets, and white blood cells. Lymphocytes are produced in the marrow and play an important part in the body's immune system. They are one of the main types of immune cells. Lymphocytes are divided mainly into B and T cells. B lymphocytes produce antibodies. They are proteins that recognize foreign substances and attach themselves to them. B lymphocytes, or B cells, are each programmed to make one specific antibody. They function in the humoral immunity component of the adaptive immune system by secreting these antibodies. When we say adaptive immune system, we are referring to adaptive immunity, which is an immunity that occurs after exposure to an antigen either from a pathogen or a vaccination. Definition: primary B-cell immunodeficiencies refer to diseases resulting from impaired antibody production, meaning there are problems with B-cell development so they can't make antibodies properly. B-cell immunodeficiencies are characterized by reduced serum immunoglobulins and a lack of antibodies. Immunoglobulins and antibodies are just the same. They act as a critical part of the immune response by specifically recognizing and binding to particular antigens such as bacteria or viruses and aiding in their destruction. Therefore, with B-cell deficiencies, there aren't enough antibodies, which make us very susceptible to infections. B-cell deficiencies result from molecular defects inherent to B cells, failure of required interactions between B and T cells, loss of appropriate bone marrow or germinal center responses, and defects of immune regulation. These defects result in a variable loss of B cells, reduction or absence of serum immunoglobulins, and loss of antibody function. B-cell immunodeficiencies are categorized into the following. Number 1, a severe reduction in all serum immunoglobulin isotypes with profoundly decreased or absent B cells, recognized as agama globulinemia. Number 2, severe reduction in at least 2 serum immunoglobulin isotypes, typically IgG and IgA, with normal or low number of B cells. Number 3, severe reduction in serum IgG and IgA with normal or elevated IgM with normal numbers of B cells, typically recognized as hyperigm syndrome. And number 4, isotype or light chain deficiencies with generally normal number of B cells. Now let's dive into each category and describe each of their pathogenesis. Number 1, agama globulinemia. Severe reduction in all serum immunoglobulin isotypes with profoundly decreased or absent B cells. Agama globulinemia is characterized by absence of circulating B cells with severe reduction in all serum immunoglobulin levels. The classic disorder of B cell development is X-linked agamaglobulinemia, or XLA, first described in 1952 by Ogden Bruton. The hallmark of XLA is the lack of circulating B cells. For the pathogenesis, X-linked agamaglobulinemia is caused by a genetic predisposition which causes a mutation of the BTK gene on the X chromosome. The BTK gene provides instructions for making a protein called Bruton tyrosine kinase, which is essential for the development and maturation of B cells. So when there is a mutation of the BTK gene, it causes impaired function of the BTK. Then there will be a decrease in the phospholipase C signaling downstream of the BTK, which then impairs the maturation of B cells from precursor cells. This causes impaired B cell function. There is an inability to produce all classes of immunoglobulin proteins or antibodies. So when this happens, there is a complete deficiency in the adaptive humoral immunity. Since there is an inability to produce immunoglobulin proteins, exposure to antigens fail to result in the generation of antibodies. This means that there is an increased susceptibility to infection, especially bacterial infections such as bacterial pneumonia. There are also undetected or decreased levels of IgA, IgG, and IgM, and decreased or undetectable antibodies in response to immunizations and common antigens. Next is CVID phenotype, severe reduction in serum immunoglobulins with normal or low B cells. What is CVID? CVID, or common variable immunodeficiency, is a disorder that involves the following. Number 1, low levels of most or all of the immunoglobulin Ig classes. Number 2, a lack of B lymphocytes or plasma cells that are capable of producing antibodies. And number 3, frequent bacterial infections. CVID is shown to be a genetically determined primary immune defect. The result of these defects is that the patient doesn't produce sufficient antibodies in response to exposure pathogens. As a result, the patient's immune system fails to protect them against common bacterial and viral infections. For the pathogenesis of CVID, there is a failure in the differentiation of B lymphocytes, which causes B cells to proliferate abnormally or terminally differentiate into plasma cells and/or memory B cells. This causes a block in B cell development. Failure in the differentiation of B cells into immunoglobulin-secreting plasma cells occur. And then there is decreased serum immunoglobulin IgG with a decrease in serum IgA and/or IgM along with a defective specific antibody production. Signs and symptoms of CVID include hypogamma-globulinemia, recurring infections involving the ears, eyes, sinuses, and nose, viral infections that usually respond to antivirals, enlarged lymph nodes, fatigue, abdominal pain, bloating, nausea, vomiting, diarrhea, weight loss, and other non-common clinical features. Next is hyperigm syndrome, severe reduction in serum IgG and IgA with normal or elevated IgM and normal B cell numbers. The initial terminology of hyperigm syndrome is really X-linked immunodeficiency with hyperimmunoglobulin M. It is a rare form of primary immunodeficiency disease caused by mutations in the gene that codes for CD40 ligand. CD40 ligand is expressed on activated T lymphocytes and is necessary for T cells to induce B cells to undergo immunoglobulin class switching. Patients with hyperigm have markedly reduced levels of IgG, IgA, and IgE but have normal or elevated levels of IgM. Because CD40 ligand is required in the functional maturation of T lymphocytes and macrophages, patients with hyperIgM also have a variable defect in T lymphocyte and macrophage effector function. Different genetic defects cause hyperIgM syndrome. The vast majority are inherited as an X-linked recessive genetic trait, and most sufferers are male. Signs and symptoms of hyperIgM include infections such as pneumocystis pneumonia, a form of pneumonia that is caused by the yeast-like fungus Pneumocystis jirovecii. There is also hepatitis, chronic diarrhea, hypothyroidism, neutropenia, arthritis, and encephalopathy. Now for the last category of primary B-cell immunodeficiencies. Number 4, we have the isotype, light chain, or functional deficiencies with generally normal numbers of B cells. This includes the selective IgA deficiency or cGAD, selective IgM deficiency, kappa chain deficiency, specific antibody deficiency with normal Ig levels and normal B cells, and last, transient hypogammaglobulinemia of infancy. First, we have the selective IgA deficiency or cGAD. The selective IgA deficiency is the most common primary antibody deficiency. Although an underlying gene defect has not been identified in cGAD, impaired switching to IgA or a failure of IgA producing B-cell maturation into IgA-secreting plasma cells has been investigated. 2/3 of patients with cGAD remain asymptomatic, whereas symptomatic patients suffer from allergies, recurrent sinopulmonary and mucosal infections, both infectious and non-infectious gastrointestinal diseases was also noted. The pathophysiology of cGAD remains unknown. Next, we have the selective IgM deficiency. The selective IgM deficiency is a very rare immune disorder in which no serum IgM is detected and other isotypes are preserved. The causes for this are unknown. Number 3 is the kappa chain deficiency. The kappa light chain deficiency is a rare autosomal recessive disease caused by mutations in the immunoglobulin kappa. The pathogenesis of the disease is a failure to express kappa chains, and as a result, all immunoglobulin molecules express only lambda light chains, but the reason is unknown. Although this disease could be seen in association with other conditions, it can be asymptomatic. Number 4 is specific antibody deficiency with normal Ig levels and normal B cells. This is characterized by normal immunoglobulins, IgA, IgM, total IgG, and IgG subclass levels, but with recurrent infection and diminished antibody response to polysaccharide antigens following vaccination. The pathophysiology is not established, but there are studies suggesting a B-cell repertoire defect or a defective splenic marginal zone interactions. Patients with SAD have increased susceptibility to recurrent bacterial sinopulmonary, and a subset of patients have a history of allergy, particularly allergic rhinitis. Last is transient hypogammaglobulinemia of infancy. By definition, PHI have low Ig levels with possible involvement of IgA and less frequently IgM that spontaneously returns to normal usually within 2 to 3 years of age. It is called transient since it only lasts for a very few years. Most patients with PHI remain asymptomatic. However, in some patients, it can be associated with a higher rate of recurrent infections, especially of the upper respiratory tract. Moreover, the pathophysiology of PHI is unknown. Now that we've covered the description, the categories, the pathogenesis, and clinical manifestations of B-cell deficiencies, let's go to the diagnostic and laboratory procedures. Diagnosing primary B-cell deficiencies or defects rely first on clinical history and then on confirmatory laboratory evaluations. This includes a detailed family and infection history, age of onset, frequency and duration of treatments, and if known, organisms that might suggest a primary B-cell defect or a combined B and T-cell immune defect. Laboratory evaluations include complete blood counts, full lymphocyte panels for T-cell, B-cell, and NK cell subsets, quantitative serum immunoglobulin levels, and evaluation of specific antibody responses to both protein and polysaccharide antigens. Interpretation of immunoglobulin levels should factor in the age of the patient. IgG subclasses can be useful but in general are interpreted only with regard to results of vaccine responses. Immunophenotyping of B and T cells is also useful, adjunct for subcategorization, prognostication, and management. Now we're at the treatment part of our video. In this segment, I'm going to talk about treatment modalities, medical management, and nursing management all in one go. The management of primary B-cell immunodeficiencies focuses largely on the prevention and treatment of infections and secondarily on controlling any complications that may develop. Adequate antibody replacement therapy for those with documented loss of functional IgG is key, with intravenous or subcutaneous immune globulin formulations being the primary cornerstone in the care of patients. Antibody or Ig replacement therapy can be administered either intravenously, also known as IVIG, or subcutaneously, also known as SCIG. IVIG is indicated for patients with primary immunodeficiencies such as B-cell deficiencies at a starting dose of 400 to 600 mg per kilogram of body weight every 3 to 4 weeks. SCIG can be given daily, weekly, every 2 weeks, or multiple times a week. As with IVIG, the typical starting dose for SCIG is between 400 to 600 mg per kilogram of body weight a month. Additionally, SCIG is a good option for those who have adverse reactions to IVIG. Microbial therapy is also used as needed for acute treatment and in some cases chronic antibiotic prophylaxis. For non-infectious complications associated with more severe B-cell defects such as chronic lung disease, gastrointestinal disease, autoimmunity, and malignancy, surveillance and monitoring for disease progression continues to be an essential part of a multidisciplinary management. Treating such complications early is critical. Immunosuppressive, anti-inflammatory, cytotoxic, and anti-neoplastic therapies are also used for the treatment of autoimmune or malignant complications of primary B-cell defects. For our nursing diagnosis, it is risk for infection related to compromised host defenses secondary to impairment in B-cell development. As nurses, our goal and objective in the management of our patient with B-cell deficiencies is to prevent infection. We want our patients to be free from infection, as evidenced by normal vital signs and absence of signs and symptoms of infection. Early recognition of infection allows for prompt treatment, so we need to recognize the signs and symptoms of infection early. We also want our patients to demonstrate meticulous hand-washing technique in order to prevent and protect themselves from pathogenic microorganisms. For our nursing management or nursing interventions, we need to assess the skin for color, texture, elasticity, and moisture. Proper skin assessment and documentation facilitates prevention of skin breakdown, which is the body's first line of defense against pathogens. We also need to routinely monitor the patient's white blood cell count, serum protein, and serum albumin. These lab values are closely linked to the patient's nutritional status and immune function. We also need to take note of the patient's current medications since some medications and treatment modalities cause immunosuppression, which can further put our patients at risk for infection since they already have deficient antibodies. We also need to wash our hands and encourage the patient to do the same. Hand washing is an effective technique to prevent the spread of infection. Moreover, we need to dry our hands with a paper towel or a clean cloth. Dry surfaces are better in preventing the transfer of microorganisms. we can also encourage the patient to eat a balanced diet and to get adequate rest, because it can reduce stress and boost the immune system. In order to limit the risk of the patient being exposed to pathogens, we can also encourage the patient to limit the number of visitors allowed. In the case of the patient being in immunoglobulin replacement therapy, whether the nurse is administering an intravenous infusion or teaching patients to administer their own subcutaneous infusion, safety should always be the first priority. Nursing responsibilities for this is to assess that the immunoglobulin product ordered is appropriate for the patient. There is also a need to assess the patient to ensure that the infusion is being tolerated. The nurse should listen carefully to any complaints and be sensitive to any alteration in the patient's baseline status. The nurse also needs to assess for any problems occurring after the infusion which may be infusion-related. These can include headaches, myalgias, fever, rashes, or a subjective feeling of general unwellness. If these problems are postulated to be infusion-related, alterations to the infusion protocol may be necessary. The nurse should also inform the patient when the next therapy is. It is important for the patient to know when the next infusion is due and what his or her responsibilities are regarding this infusion. Prognosis. B-cell immunodeficiencies severely compromise the immune system and resulting in the individual's inability to produce antibodies. The prognosis depends on the presence of severe autoimmune disease, recurrent infections causing structural lung damage, and the development of a malignancy. Patients are at risk for opportunistic and repeated infections. Even with treatment, patients can expect to have chronic pulmonary infections, skin disease, inflammatory bowel disease such as ulcerative colitis and Crohn's disease, and central nervous system complications due to enteroviral infection. Hello again, you have reached the end of the video. Again, my name is Althea and I hope you learned something, or I hope that my video was helpful and that you learned something. Again, thank you and have a nice day.